This is Soundcheck, your go-to podcast for ultrasound quality assurance, image review, and clinical education from MedStar emergency physicians. We walk through real cases, highlight what to look for, and dig into how ultrasound guides decision-making. Here's your host, Dr. Jon Watson.
Hey everybody, welcome to this episode of Soundcheck. This is a podcast where we dive into real emergency point-of-care ultrasound cases from across the MedStar health system. Each episode will walk through several great cases, highlight key learning points, and share pearls you can take back to the bedside. Our goal is to make ultrasound education practical, memorable, and directly relevant to emergency medicine practice. Every month, I am joined by a different co-host to bring a fresh perspective to the discussion. Today, I'm excited to introduce Dr. Rachel Cary, first-year emergency medicine resident at MedStar Georgetown and Washington Hospital Center. We'll kick things off by going through some fascinating cases and learning points, and then hang around for the end of the episode because we'll tackle a listener question with special guest Dr. Rukh Syed, another one of our resident physicians. Stick around, it's going to be a great episode. Let's get started. Rachel, thanks for coming to do QA with me.
Sure, absolutely.
So let's go through a couple cases here. The first one we have is an echo. Guy came in for chest pain. So what are we looking at here and how do we get this view?
Yeah, so this is our first view in the cardiac echo. This is the parasternal long view. So you're using the phased array probe. You have the probe indicator towards the patient's right shoulder, about nipple line, so fourth intercostal space, and you are just left to the sternum.
Perfect. Yep. And then let's point out some key anatomy that we're seeing here. So this chamber here outlined, what is this?
That's our left ventricle.
And then we have something moving here. It looks like a valve, and that's the
mitral valve.
Mitral. Up here we have?
That's the left atrium.
Left atrium. So what's coming through the left atrium through this mitral valve, and then ejecting through this valve here?
That's our aortic valve.
Aortic valve, right. And you have the left ventricular outflow tract going into the proximal aorta there. What about over here, the anterior portion?
Yeah, that's our right ventricle.
Right ventricle, good. So, and then deep to the heart, we have another structure here, circular caught in transverse view here. What is this?
That is our descending aorta.
Good. So this sonographer did a good job of keeping the descending thoracic aorta in view while capturing the parasternal long. But why is that important?
By including the view of the descending aorta, you can kind of decipher between a pericardial effusion and a pleural effusion.
Yep.
Based on like the location of the fluid.
Right. So pericardial and pleural effusions can look similar, especially if they're out here, posterior to the heart around this 5 o'clock position. But a pleural effusion is going to go deep to the descending thoracic aorta, whereas a pericardial effusion will come here and split between the myocardium and this descending thoracic aorta here. So this is one structure that you want to keep in view. So when we're looking at a parasternal long axis view, one of the things that we can look at is kind of the gross estimate of the ejection fraction. So what do you think about this patient's ejection fraction?
Yeah, so I think it's moderately reduced. I'm looking at the anterior leaflet of the mitral valve, and I notice how it's not fully extending to touch the LV wall. So I would say moderately reduced. The squeeze looks mediocre.
Okay, great. So you mentioned the mitral valve, so let's talk about that a little bit more. So here they're doing a technique that's called EPSS, which is basically a way that you can quantify the movement of that anterior leaflet of the mitral valve. So the mitral valve has these two leaflets here, one anterior and one sort of more posterior. You can't make out quite as well, but about right here. And you can put M mode on, and then put your M mode cursor over the distal end of the mitral valve, and then watch for the motion of that mitral valve, and you'll create this graph here that we see below. So this M mode graph shows movement against time. So the x-axis is time, and the y-axis is the movement along this line that you set and you can adjust. So we're here about halfway down, we see where the mitral valve is moving, and that corresponds to this line here.
Gotcha.
And we have two peaks, right? So the one is called the E wave, and the next is called the A wave. So we can use a measurement called, or a technique called the EPSS, which stands for E-point septal separation. So do you remember what a normal EPSS measurement is?
I think it was less than 7 millimeters.
Right. So if you're like in a normal, healthy heart, the mitral valve should basically be almost making contact with the septum, and sometimes you don't even need to do this if it's very clear that the mitral valve is hitting the septum each time. But if you take a measurement and it looks bigger there, you can quantify that. So less than 7 is normal. Between 7 and 14 millimeters is moderately reduced, and greater than 14 is severely reduced. So this patient is 15 millimeters, who put this into more probably the severely reduced ejection fraction category. All right, next we have this view. What are we seeing here, and how did they go from this parasternal long to this view?
Yeah, so this is our parasternal short view, the second view typically, and you actually keep the probe positioning. You just rotate it 90 degrees counterclockwise towards the patient's right hip.
Perfect. Yep. So now we're seeing the ventricles sort of side by side, right? And we're at the level we call the papillary muscles. So we sometimes describe this sign as like the dinosaurs fighting. You see these little things here that look like little T-Rex arms that are boxing each other. Those are the papillary muscles that are sticking off the side of the left ventricle. That's opposed to the parasternal short at the level of the mitral valve, which looks like the fish mouth. And then if you go up even higher, you can sometimes see the aortic valve, and they call that the Mercedes-Benz sign. So another way that you can estimate ejection fraction here that they didn't do in this study is with something called fractional shortening as well. So that's when you take the end diastolic volume of the left ventricle and the end systolic volume of the left ventricle, and then analyze the ratio between them and calculate essentially the percentage change to see how much volume change there is between those two phases of the cardiac cycle. So that's another way we can estimate EF. Do you see any obvious wall motion abnormalities in this?
I don't. I think the wall is equally squeezing inward.
Mm-hmm. Yeah, so what I typically do is kind of like just put my finger or cursor here right in the center and just look to see all the walls are sort of moving in more or less similarly to my finger or the cursor in the center of the screen. Sometimes if you have like an inferior wall STEMI, for instance, or some sort of other insult to the heart, you'll have a regional wall motion abnormality where part of the wall is not moving as much. But right here, we just have mostly like global hypokinesis. So where's the RV in this situation?
Yeah, so the RV is more to like the left of the screen, kind of the crescent-shaped ventricle.
Right. So this is the RV here. It's not super well seen in this picture, but it has that crescent moon shaped here hugging the left ventricle. And we don't see any of the other findings. Sometimes we see like the D sign where the septum gets flat here because of increased right heart pressure. So now we have the apical 4 view. So how do we obtain an apical 4?
Yeah, so a different view, you're going to take the probe, and it's different for every person, but usually it's more lateral. It ranges between like mid-clavicular and mid-axillary, and you're trying to point it up towards the heart at the apex, so around the point of maximal impulse, maybe 5th or 6th intercostal space.
Mm-hmm. Good. Yeah, so it's a little bit variable in each person, just based on sometimes the size of the heart, if they have dilated cardiomyopathy or CHF for whatever reason. But this is a good example of an apical 4 because we see the ventricles are aligned basically right on top of the atrium. So we have the left side of the heart here, the left ventricle, left atrium here, and then the right ventricle and right atrium here. We can see pretty clearly the mitral valve here and the tricuspid valve. You can actually see a little bit of the chordae tendineae and the papillary muscles here in sort of a longitudinal view. So the best view of an apical 4 is to have the interventricular septum in the middle, basically straight up and down. And the ventricles aren't foreshortened, meaning that they're like smaller than they usually are. So getting a good apical 4 is to get the ventricles as long as possible with the atria stacked on top or underneath like this. So what can you tell us about like the chamber size, the relationships between the LV and the RV, like what's normal, what would be abnormal?
Yeah, so I believe normally the RV is about 2/3 the size of the LV. Any increase in that ratio would indicate maybe potential right heart strain, either acute or chronic. And as I'm looking at the ventricle size, I don't see that the right heart is enlarged. It looks about appropriate, so I don't see any signs of right heart strain.
Yeah, perfect. Yeah, when that ratio approaches 1-to-1, you get more worried about right heart strain. And like you said, it could be chronic from pulmonary hypertension or chronic PE, but that is an abnormal ratio. So right now they're trying to show something called TAPSE. You remember what TAPSE stands for?
Yes, we just talked about it. It's tricuspid annular plane systolic excursion.
Good. So that is another technique where we're using M mode, but instead of looking at the valve, the tricuspid valve, we're looking at what's called the tricuspid annulus, which is a soft tissue around the valve, and it's on this lateral free wall. So they have the cursor over the lateral free wall of the RV, and you're measuring the up and down movement of the RV in that area with M mode. So you'll get a graph like this when you put the M mode cursor over this area, where you can measure the distance between a peak and a valley, and you'll get a measurement. In this case, it's 23. So what does 23 mean?
23, I think, is normal, right? Because we want above 16?
Yeah.
Okay.
Yeah, so above 16 is normal. That means that the heart is, moving well, or the right heart is moving well. But when you have right heart strain or RV hypokinesis, sometimes you're not going to have that up and down movement in that area. So your measurement is going to be lower than usually 16 or 17. What's this last view that we're looking at?
Yeah, so this is the subxiphoid view that you get with aiming the probe directly under the xiphoid process, essentially. So almost parallel to the bed, very, very flat with the patient supine.
Yeah, good. So sometimes people struggle with getting a good subxiphoid view like this. What are some tips that you can use to get a better view if you're struggling?
So you can have the patient take a deep breath, and another thing you can do is you can kind of use the liver as an acoustic window, because the waves travel pretty smoothly through the liver. So you can kind of go a little bit more right, but then still aiming towards the heart.
Right. Yeah, I think that positioning really helps. Just having them lay down flat, taking a deep breath in is going to contract the diaphragm down. The heart's basically sitting on top of the diaphragm, and then it will move down towards your probe with it, more towards the abdominal cavity, and get you a better view. With echocardiogram in general, you can get better views if you actually turn the patient to the left side as well. So that'll bring the heart forward along the chest, and will help you get a little bit better views, is even on your apical floor, just like rolling them to the side. It's really helpful. All right, next case is a young woman who came in with a positive pregnancy test and had abdominal pain. So what type of exam are they doing here?
Looks like it's a fast exam. This is a right upper quadrant view. They're using the abdominal probe. It's also called the curvilinear probe. Better depth and more useful for viewing like deeper structures like the liver and the kidney.
Great. And you can tell that based on the footprint of the probe, right? Where it has this curvilinear appearance versus linear probe, which is straight across, or phased array, which sort of comes out like a triangle from one origin. So as we're scanning through the right upper quadrant, we have the probe marker oriented towards the patient's head in this case, and we're seeing the liver here in the left side of the screen. We see a little bit of the diaphragm as well, curving around this hyperechoic linear structure that's curving around the liver here. And then we have the right kidney as well. So what's the space between the liver and the kidney on the right side?
Yeah, so that's called Morrison's pouch.
Yep. So that's just a kind of like a potential space where fluid can accumulate. Do you see any fluid there?
I don't.
Yeah, no, me neither. What are some other areas that we would look for in the right upper quadrant besides Morrison's pouch?
Sure. So you can look actually right under the liver, subhepatic, I guess, and it actually looks like there's a tiny bit of free fluid underneath the liver tip.
Right. Yeah. So sometimes the more sensitive area to look for early fluid is at the liver tip here, and you can see a little bit accumulating in this area here, and a little bit right here as it advances through.
Yep, I see it.
Yeah, right here. So this is subtle, but is a positive fast. So let's go through the rest of the fast. What's this view here?
Yeah, so this is your left upper quadrant. I can see the spleen towards the left side of the screen, and then the left kidney.
Good. You see any fluid accumulating there?
I don't think I see any fluid.
Yeah, no, me neither. So it looks like a pretty normal left upper quadrant. The sonographer's, of course, dealing with issues with rib shadowing through some of the views, which is kind of inevitable as you're scanning through the left upper quadrant, since the left upper quadrant view is a little bit more superior than the right upper quadrant. So you're sort of like in the lower ribs. But overall, it's a diagnostic image, but it's negative. Now we have suprapubic, and we're looking for any free fluid kind of outside of the bladder. So the bladder's here, looks pretty well circumscribed. I don't see anything obvious posterior to that. And then we have the uterus here. So what are you thinking, though, in this case? You have a positive FAST, positive pregnancy test. So you look at the uterus here, and with that appearance, does that look like a pregnancy?
I don't definitively see a pregnancy in that uterus.
Yeah, me either. So you'd be concerned for what?
Potential
Diagnosis.
ectopic or pregnancy of undetermined location.
Yeah, right. So Riley, of course, went to the pregnancy scan as well. So this is transabdominal pregnancy scan, looking through the bladder here. Bladder's not incredibly full, so sometimes it's hard to get really good images. One of the tips to get good transabdominal pregnancy ultrasound images is to make sure that the patient doesn't void beforehand, so you have a nice full bladder that you can scan through. But you can see the uterus here posteriorly, and you definitely don't see a yolk sac that would be consistent with the early IUP. And then going through long view as well, don't really see anything within this uterus, so I'm even more concerned for ectopic pregnancy now. So the question is, where is that ectopic? We haven't found it yet. It's definitely not intrauterine. So we'd then be looking for the adnexa. So now we're just shifted over towards the patient's right side. We're in a transverse view right now. You can see right here is the pelvis bone with shadowing behind it. So all this between here is sort of like the adnexal structures. It's not super well seen on transabdominal imaging, the specific ovaries and things like that, but I don't see any obvious free fluid or any adnexal mass there. We'll do the same thing with the left side. And nothing really jumping out as obvious. But I will say this patient did go down, then had a transvaginal ultrasound performed in our radiology department, and which confirmed an ectopic pregnancy. So they ended up going to the OR for ruptured ectopic. So I think good teaching points for this case would be that if you have an ectopic pregnancy, but you have a positive FAST, that's surgical and needs to go to the OR versus medical management with methotrexate if it's a ruptured ectopic. Okay, this next case, we're looking at a guy with abdominal pain. So what organ are we looking at now?
Yeah, so we're looking at our gallbladder right now.
Yep. And what orientation is the gallbladder? Is it transverse, longitudinal?
Yeah, I think it's transverse right now.
Yep, because it looks kind of circular orientation, short axis, people call it as well. And then anything abnormal you see about the gallbladder?
Yeah, I see some gallstones.
Yep. So gallstones are here at the 7 o'clock position, and you can tell that they're gallstones or likely to be gallstones because of the shadowing. So we see the posterior shadowing here. Stones with shadowing deep to it. So then we're going to go ahead and measure the wall of the gallbladder. So what do you think about the wall thickness here?
Yeah, I think it's pretty thick. I think normally the gallbladder wall is like 3 millimeters or less, and this one appears thickened.
Right. And you notice that they chose this portion of the gallbladder wall to measure. Why they choose this anterior wall rather than any other portion like this posterior wall?
Yeah, so the posterior wall is impacted by artifact, the posterior acoustic enhancement artifact, and sometimes can be like falsely elevated.
Good. Yep, so there are some other reasons why the gallbladder wall can be thickened rather than just from acute cholecystitis. Any others that you think why the gallbladder wall will be thick?
Yeah, ascites can cause increased gallbladder wall thickness, and then other conditions like CHF as well.
Yep. Sometimes hepatitis or low albumin states also can cause an artificially thickened wall, but usually you wouldn't have these other findings of potential cholecystitis like the gallbladder stones, sometimes the edema within the walls, which we didn't mention, but we see that there's some edema within the gallbladder wall here. Is this hypoechoic or anechoic area here makes us get concerned that there's fluid within that gallbladder wall itself. So if you were to put the probe directly over the patient's abdomen in this spot and push down, what's that sign called, and how would you usually interpret it?
Yeah, so that's Murphy's sign. And a positive Murphy sign would be the patient winces in pain or voluntarily guards from your hand.
Right. Yeah. Specifically, we call it the sonographic Murphy sign to differentiate that between the other exam maneuver Murphy sign, where they stop inspiring when they tell them to take a deep breath and you're palpating the gallbladder fossa area. So direct pressure with the ultrasound probe will elicit pain in sonographic Murphy sign. So now we have a longitudinal view of the gallbladder here. You want to describe some of the findings?
Yeah, sure. So again, I'm seeing the stones longitudinally there. And then I also see a little bit of sludge.
Yep. So there's some sludge here layering in a dependent region. This hypoechoic area here, it's not super bright and doesn't shadow as opposed to stones, but it can also be found in cases of cholecystitis. So in this case, we have sludge and stones. There's another good view of the stones here shadowing. And then lastly, we usually put the patient into lateral decubitus position as well, because some structures like sludge and stones are going to be mobile and they'll change position when a patient moves from side to side or like is laying on their left side. But something like a polyp that's stationary within the gallbladder wall, which can sometimes mimic those, is not going to be mobile technically. All right, so this patient has cholecystitis. You want to summarize some of the findings that we're seeing and how we can diagnose cholecystitis on ultrasound?
Yeah, so thickened wall greater than 3 millimeters, also with pericholecystic fluid, positive sonographic Murphy sign, and the other one is...
Gallstones.
Yes, okay.
Yep. Got them all? Perfect. All right, this next case is a guy in his 40s who came in with worsening jaundice and abdominal distension. And it looks like they're doing a fast exam. So what do you see notable in the fast exam here, Rachel?
Yeah, so I see liver and kidney, and I'm seeing a lot of free fluid in the abdomen, and I'm also seeing like an irregular contour of the liver.
Right. Yep, so we see the kidney here at the beginning of the clip. And the liver has this kind of nodular appearance to it. This is consistent with cirrhosis as well. And you mentioned a lot of free fluid. So you think this patient has like a massive hemoperitoneum? No trauma in this case.
Yeah, I don't necessarily. Given if I know a little bit about the patient's history, I would probably suspect acidic fluid versus blood.
Yeah. It can be hard to tell though, sometimes on ultrasound because they're both anechoic and you can't necessarily tell the difference between blood and ascites. But in the absence of trauma, this guy comes in and he says, I get paracentesis every week. This is likely more consistent with ascites, like you said. So now we'll move over to the left upper quadrant. What organs are we kind of focusing on there?
Yeah, so the spleen and the left kidney. And it looks like I see a little bit of perisplenic fluid.
Yep, there's a little bit around the spleen here. It can be challenging in the left upper quadrant, again, to get good pictures because of the rib shadowing. So you see a rib shadow here and a rib shadow here, right, that are kind of obscuring our view. But if we focus in this area here, we do see some anechoic fluid sort of just here anterior to the spleen and a little bit around this portion. So that's just more intra-abdominal free fluid. Let's go down to the bladder now. It kind of looks like there's two bladders in this situation, right?
Yeah.
So it's kind of hard to tell just based on a couple of views which one is actually the bladder. I think it's probably the one at this position here is probably the bladder, and then down here you see actually some probably bowel loops that are in ascites fluid that sort of looks like the bladder.
Okay.
But we know that's definitely abnormal. And then they're doing a longitudinal view of the same thing. We see two bladder-looking structures, which we know is not possible, so it's likely consistent with that continued free fluid. In this case, actually, the person was complaining of his hernia he has around his belly button was getting larger as well. So they put the probe on right over top of the hernia sac near his umbilicus, and what you're seeing here is that this stripe of the tissue is the abdominal wall and the peritoneal lining, and then you have herniation of this bowel contents and this ascites fluid into this hernia space. So this is just a umbilical hernia with ascites in it. see it again in another view. This right here is basically the lining of the abdominal wall and then bowel prolapsing out into that. So this was a non-strangulated hernia, was easily reducible, and he ended up getting discharged.
Okay.
Okay, last case we have is actually a young woman, 18 years old, who came in, had a history of pericarditis in the past, and it's coming in today with chest pain and shortness of breath. So they're doing an echo here. We've already gone through some of the echo findings on a previous case. So can you break down this peristernal long axis view, what you're seeing?
Yeah, I'm seeing a pretty significant pericardial effusion, and the way I know it's pericardial is because it's kind of like circumferential and passing like above the descending aorta.
Right. So we see the descending thoracic aorta right here, the effusion here splitting between the myocardium and the descending thoracic aorta, and it is circumferential. What about the ejection fraction and the overall LV function based on if you did like an EPSS for her? What would you expect?
Yeah, actually probably normal. The mitral valve looks like it's moving and slapping that other wall pretty significantly. So probably normal, which would give us a false illusion that the patient's okay.
Yeah, because we'll see that she's probably not okay. She's developing something potentially concerning. So in this, what do you think about the LV cavity itself? It looks fairly small to me.
Yeah. It's kind of, the walls are kind of touching each other.
Yeah, so it's probably suggests that the LV is like kind of underfilled, which can be one of the problems when you develop tamponade physiology, which is what we're going to get into for this case. So looking at the peristernal long, what are some other findings of tamponade? Well, first off, clinically, what was a kind of classic teaching for tamponade?
Yeah, so the triad of symptoms signs would be distant heart sounds, hypotension, and JVD.
Right.
And then another
It's
thing.
called a Beck's triad.
Yeah.
But kind of hard to ascertain in the ER sometimes, the distant heart sounds and everything like that.
Yeah.
So sonographically, though, what are some changes that we can see when you'd be concerned for tamponade?
Yeah, so you can see like right ventricle collapse, which would be kind of like paradoxical because normally we want the right ventricle to be filled during diastole, but due to this fluid around the right ventricle, it's actually decreasing in size.
Right. Yeah, so RV diastolic collapse is one of the big findings because during diastole, when the mitral valve and the tricuspid valve are open, the ventricle should be getting bigger. But when you have collapse of the RV, because the RV and the RA are more susceptible to those external pressure changes due to just being a lower pressure system than the left side of the heart, you see some collapse and hemodynamic change. So let's go over to the peristernal short axis now. We notice that there's the similar underfilling of the left ventricle. No obvious like wall motion abnormalities, but again, we see that circumferential effusion here, anterior and posterior to the heart. But what do you notice about the RV here?
Yeah, it's small, and it's also getting smaller when it shouldn't be, right?
Yeah, specifically in this area, you see this bouncing movement of this RV, that you get concerned about pressure-related changes and collapse of the RV there. Sometimes people call it as a trampoline sign. Looks like a little person kind of jumping on a trampoline right here. Now we have subcostal view. What do you think about this image?
So it's not really a great image. I don't know if I can point out anything in particular.
Yeah, I'd probably just say this is kind of a non-diagnostic image, and maybe hard because she's short of breath or uncomfortable or whatever, but you can't really see the heart that well, so I wouldn't really make any decisions based on this. So one thing that you can do is try to have them take a deep breath, and we'll bring the heart closer to your probe, but she may not have been able to do that in this case, so we'll just use our other views. Like the apical 4, as we discussed earlier, we have the left ventricle on the right side of the screen with the left atrium deep to that. And then here we have the right side of the heart. And then we see some of that pressure-related change as well. You see the kind of the RV wall bouncing a little bit in. That's concerning for a tamponade physiology. Lastly, if you're not sure what phase of the cardiac cycle you're in, right, because we said that there should be RV diastolic collapse, you can use M mode. So we did this earlier with EPSS, and they're basically doing an EPSS, but we're also looking at the timing of the opening of the mitral valve and looking at the relationship between that and the RV free wall. So here, as we did before, we have the EPSS tracing, the E wave and the A wave here. So ejection fraction wise, they're touching the septum, so that's normal. But then if we look at the RV wall here, what do you notice? As the pattern, as diastole starting here, you see that there's actually the RV is going away from your probe, which means it's dipping inward and collapsing a little bit. So this finding is concerning for tamponade. In this case, they didn't include an IVC, but if you were to include an IVC exam for this patient, what would you expect?
Yeah, pretty enlarged because all the blood is unable to drain into the right atrium.
How much fluid needs to accumulate before you develop pericardial tamponade?
Is it more about the rate of the accumulation of fluid versus the actual amount?
Right. Yeah. So some patients, where it's accumulated really slowly due to cancer or renal disease, whatever, sometimes they can have a massive amount in their pericardial sac without developing any hemodynamic change. But when it develops really acutely, like I suspect in this case, even small or moderate amounts of fluid can cause pericardial tamponade pretty quickly because the heart doesn't have time to accommodate to that change. Well, thanks, Rachel, for going through those cases with me. What are some of the teaching points that you can take away that you want to share?
Yeah, so for the cardiac, 4 different views, some tips on getting some better images would be potentially having the patient be in left lateral decubitus, also having the patient take a deep breath in and hold it for a little bit. As far as for our gallbladder study, just some findings for acute cholecystitis would be presence of stones, increased wall thickness, pericholecystic fluid, sludge, and/or positive sonographic Murphy sign. If you have a patient with a positive pregnancy test and a positive FAST indicating free fluid in her abdomen, you would suspect ectopic pregnancy until proven otherwise. And then lastly, when you're concerned about cardiac tamponade in a patient, it's more about the rate of accumulation of the fluid versus the actual amount of the fluid.
Thanks again, Rachel, for doing all this quality assurance review with me and for sharing all those great teaching pearls. Now we're going to move into the listener Q&A section. We've got a great question here from one of our residents. If you'd like to submit a question to be answered on the podcast, just head over to speakpipe.com/soundcheck and record your question there. This one comes from Dr. Zlupko, one of our emergency medicine residents. Let's take a listen.
Hey, Dr. Watson, TJ here, one of the residents. Just had a quick question for you. So recently on trauma, I had a patient, initially FAST exam negative, sent over to CT, which found free fluid. My question for you was, why did this happen? And do you have any tips for better ensuring the FAST exam is truly negative?
That's a great question, TJ. To help go over the FAST exam and tackle your question, I wanted to bring in one of our excellent PGY2 residents, Dr. Rukh Syed. Let's listen in. So today we have Rukh walking us through the FAST exam. So let's start with the basics. What is a FAST exam? What's it stand for? And what are the indications?
So the FAST exam stands for a focused assessment with sonography for trauma. It is a quick bedside ultrasound that can detect free fluid in the abdomen, pelvis, or the pericardium. Its most common indication is for an unstable patient, but it can also be used in non-trauma situations, like using it for an assessment for a ruptured ectopic or tamponade. The EFAST is just the extra lung views, which can assess for pneumothorax and hemothorax.
Perfect. So let's walk through how to get the images. But before we do that, let's talk about probe selection. What probe do you use?
So you can either use the curvilinear or the phase array probe. The curvilinear does give you a wider field of view, but the phase array probe will get between the rib spaces better. Honestly, it just comes down to what is available to you, but either one can be used for these scans.
Yeah, exactly. A lot of departments only have phased array, so if that's available to you, you have to use it. So walk us through your technique in the right upper quadrant.
So for the right upper quadrant, we are going to place the probe in the mid-axillary line at about the 8th to 11th rib spaces with the indicator pointing towards the patient's head. You can sweep through to visualize the liver, the right kidney, and the diaphragm. The goal for this view is not just to find Morrison's pouch, but also you don't want to forget to sweep inferiorly to include the liver tip, which is one of the most sensitive areas for free fluid. For Morrison's pouch, the free fluid will appear as an anechoic collection, and it'll look like a stripe between the kidney and the liver.
And what about the other views? So let's do the left upper quadrant.
So the left upper quadrant is similar to the right upper quadrant, but you want to place the probe more posteriorly and superiorly. It's typically at the posterior axillary line, and the best way to get a good view of it is put your knuckles to the bed. And in this view, you'll see the spleen, the left kidney, and the diaphragm. Often here, you'll mostly see the free fluid collection between the spleen and the diaphragm.
Great. What about the pelvis?
So for the pelvis, you want to place it above the pubic symphysis, and you want to get both transverse and longitudinal planes. In the transverse plane, you want the probe marker to be to the patient's right side, and then the longitudinal, you want the probe marker to be towards the patient's head. You want to also make sure that you decrease the gain in the far field just to avoid any false negatives. In males, you want to look posterior to the bladder in the rectovesical pouch, and in females, you want to check the pouch of Douglas, which is behind the uterus.
Great. And the last of our 4 standard fast exam views is the subxiphoid.
So the subxiphoid view, you want to angle the probe, and once again, you can use either the curvilinear or the phase array probe. Sometimes the phase array is easier, but depends on what you have. But you want it under the xiphoid, and you want it almost completely flat. The goal is to identify any pericardial fluid, and if that window is bad, you can use a parasternal or apical window.
Yeah, and there's also the concept of the EFAST or extended fast. Can you elaborate on that?
Yeah, so the EFAST essentially just adds the lungs to the FAST exam. If you are scanning the front of the chest, you want to go to the anterior chest and the midclavicular line. Absence of lung sliding, which you can quantify using M mode, you would see a barcode sign, and that could indicate pneumothorax. And if you see free fluid in the thorax, that could potentially indicate hemothorax.
So what are some of the common pitfalls when they're doing the FAST exam?
So common pitfalls, there's a couple of big ones. Having incomplete views, like not seeing the tip of the liver when you're doing the right upper quadrant, or missing small pockets of fluid. You can also mistake normal structures or fluid for pathology when it's just normal variation. Too much gain or too little depth can obscure the view for free fluid. And then forgetting that a single FAST doesn't rule out injury. So small bleeds or retroperitoneal injuries may not be detected. In terms of test performance, the FAST exam has a sensitivity around 70 to 85% and specificity of 95 to 100%, which is why serial FAST exams are sometimes indicated if your suspicion remains high.
Great. So in an unstable trauma patient, if you see the fluid, how do you interpret that?
In the context of trauma, especially if it is an unstable patient, we want to assume that it's blood until proven otherwise. So the patient should be prepped for the OR or have serial FAST exams done.
All right, great. Thanks for walking us through that, Rukh. Can you summarize the exam and some key points?
Sure. So the FAST is a rapid bedside ultrasound that looks for free fluid in the peritoneal, pericardial, and pleural spaces. The most sensitive area in the right upper quadrant is Morrison's pouch and the liver tip, but you have to make sure that you sweep through all your windows. The EFAST will add the chest component, which includes the lung views to evaluate for pneumothorax. The exam overall is highly specific, but only moderately sensitive, so a negative exam doesn't rule out an injury. In unstable trauma patients, any free fluid should be assumed to be blood and managed surgically.
Great. Thanks, Rukh, for joining us and adding all those tips.
Thank you.
Well, that's all for this episode. Remember, if you want to submit a question, record your audio at speakpipe.com/soundcheck. A big thank you to our co-host, Dr. Rachel Cary, and to our special guest contributor, Dr. Rukh Syed. For more resources and a full list of all episodes, visit mepsano.com or check us out on YouTube at youtube.com/MedStar Emergency Physicians. We'll be back next month with more great cases. Until then, go out and put these pearls into practice.